Hello friends, welcome to King's Crux. It's been a long time since we've had a very comprehensive discussion, so I thought we can have one on a very obscure but a very important vision threatening, in fact life threatening condition called scleritis. So it is going to be a complete course. We'll start from A to Z on this very important topic because it very often mimics like a conjunctivitis, which is a very common disease what we see in everyday OPD practice. But differentiating scleritis from other types of acute red eye is of prime importance. So we'll discuss about that in this lecture. Now understand, you are the hero here, you are the Batman, and you're faced with these multiple villains. You have the different types of villains here. Now these villains resemble the acute red eye conditions. It can be an acute conjunctivitis, it can be an acute uveitis. There are so many conditions which can produce this acute red eye. But the talent lies in picking out the right villain or the main villain. In our case, it's going to be the scleritis. So the analogy is this. Now you can see that there are many villains of acute red eye. It can be an acute uveitis, a keratitis, an angle closure glaucoma, an acute conjunctivitis. But of them, this guy is our villain. So picking him out of this lot is the first challenge. The second challenge is, like this villain, he has a cousin who is very innocent. He closely resembles him. It is called as the episcleritis. So the second challenge lies in differentiating scleritis from episcleritis. But the challenge or our job doesn't end there. The scleritis is most often manifested by these occult systemic autoimmune disorders, because unless we know what causes the scleritis, our job is not fulfilled. So who has sent this villain to attack the eye? That is the third challenge. So we have three challenges here. First, I will discuss about scleritis in general, okay, and we will discuss how we can differentiate both. We'll discuss the autoimmune disorders, then finally we'll take up to the acute red eye. So that we will focus on the topic first, we'll end with an approach to acute red eye by the end. So we'll have a very good conceptual overview of the entire spectrum of acute red eye diseases. So let's start with the discussion. We'll talk about the anatomy first, the very basic anatomy. Then we will differentiate episcleritis versus scleritis. Thereby we will talk about scleritis and the systemic manifestations or the systemic disorders which can produce scleritis, the management, and we'll end with the approach to acute red eye. I hope that's fine till now. Let us jump start into the anatomy part of it. See, first and foremost, there are three layers of sclera. You have an episclera, you have stroma, you have lamina fusca, and then you have the choroid underlying the sclera. So this is the picture. So this is from out, this is the inner part. Now the stroma and lamina fusca are together called as the sclera proper. So ideally speaking, episclera is a separate tissue. It's a highly vascularized tissue, and overlying the episclera is going to be your tenons, and overlying the tenons is going to be your conjunctiva. But as we move towards anteriorly of the eyeball, both the episclera and the tenons will fuse together, thereby making the demarcation difficult. So that is an important point, because within these three layers of sclera, okay, we're going to discuss the three important levels of blood vessels. The first is the conjunctival vessels, which are going to be overlying on the conjunctiva. The second is the superficial episcleral vessels or superficial episcleral plexus, which is going to overlay the tenons fascia. In other words, the episclera as well, because both of them fuse anteriorly. The third level of blood vessel is going to be on the sclera, that is a deep episcleral plexus. Note that you don't have any blood vessel in the sclera, which means sclera is relatively avascular, just like your cornea. And also they're opaque, and that's why any problem with sclera, it's difficult to treat, because sclera is opaque. It doesn't offer much of penetration of drugs as such, and since it's avascular, the chances when it gets infected or inflamed, the resolution becomes very difficult because of the avascularity and the opaqueness of sclera. So we have seen the three levels of blood vessels, the conjunctival, the superficial episcleral and the deep episcleral or the scleral plexus. So why are they important to understand? Because conjunctival vessels will be infected, or I would say conjunctival vessels are congested or dilated in conjunctivitis, right? The superficial episcleral plexus are going to be inflamed in episcleritis. The deep episcleral plexus or the scleral plexus are going to be inflamed or congested in scleritis. So that is the importance of each level blood vessel. So accordingly, you have the conjunctival vessels, the most superficial, and the deep episcleral, the deepest, and in between you have the superficial episcleral plexus. These are three vascular plexus of the ocular surface. So this table is of high importance because this is going to differentiate the different plexus and the importance of each. So as we just discussed, conjunctival plexus is the most superficial. The superficial episcleral plexus will lie at the level of Fredon's capsule, whereas the deep vascular plexus are going to lie deep to tenons or overlying the sclera. The conjunctival plexus, the arteries are tortuous where the veins are going to be straight. They are bright red in color and they are freely mobile. Contrary to superficial episcleral plexus where the vessels are straight, they will have this typical radial configuration. They are salmon pink in color. That is important. They are salmon pink in color. The deep vascular plexus are going to be arranged in this crisscross pattern. They are immobile and they are violaceous in color. So note the color difference. The color difference is that this is bright red, this is salmon pink, and deep vascular plexus is violaceous. So as we just discussed, this is going to be congested in conjunctivitis, superficial episcleral plexus will be congested in episcleritis, and the deep vascular plexus is going to be congested in scleritis. But the difference doesn't end there. The difference is conjunctival plexus and the superficial episcleral plexus, both of them will blanch with a topical vasoconstrictor, whereas your deep vascular plexus will not blanch with topical vasoconstrictor, which means that in conjunctivitis, in episcleritis, when I'm going to instill 10% phenylephrine, both of them will blanch. But if I'm going to put 10% phenylephrine or a vasoconstrictor in scleritis, the vessels are not going to blanch because that topical vasoconstrictor cannot penetrate deep enough to blanch the scleral plexus. I hope that's clear. So let us come to clinically how to differentiate episcleritis and scleritis. I'm just going to repeat whatever I've said now, but in a more important, in a very pictorial way. See, episcleritis is going to be just the congestion of the episcleral plexus, whereas the scleritis is going to be not just the congestion of the episcleral, deeper episcleral or the scleral vessels, but they are going to involve the scleral edema also. The scleral edema is the important feature in scleritis. There is an actual edema, stretching of sclera, and that's why in scleritis, because of the mechanical stretch, you experience pain. So scleritis patients will scream in pain, whereas episcleritis patients will not. So to encapsulate everything, whatever I've told you till now, scleritis, remember the 3 P's: pain, purple, persist. Scleritis patients will scream, it's painful. You will have pain intense enough to wake the patient awake from sleep. That is how the pain in scleritis is going to be. And they have this purplish or this violaceous hue. Okay, kind of this violaceous hue will be there in these patients with scleritis. But whereas in episcleritis it's going to be just bright red. And the scleritis blood vessels will persist with phenylephrine. That is the 3rd P. So persisting or not blanching with phenylephrine, purplish hue, the painful condition. These 3 P's are going to characterize scleritis, right? So let's go for a more detailed discussion. As we just discussed, episcleritis will be redness and irritation only. Very rarely it will be tender or painful. Whereas scleritis, there will be a severe excruciating pain. So minimal tenderness, moderate to severe tenderness. bright red in color, purple red in color, or violet in color. Blanching, there is no blanching. I hope you are understanding the differences between episcleritis and scleritis in a very clear way, because one is innocuous, one is benign, that is episcleritis. The other one is deadly, the other one is very lethal to the patient and to the vision, and that is scleritis. So there are some few tips to differentiate in a clinical setting. One is by using a green filter. You can use this green filter so that the red vessels or the blood vessels are going to appear black. So you can appreciate the different layers or levels of blood vessels better by keeping a green filter and observing for the blood vessels. Here you can see a corkscrew conjunctival vessel. If I were to see a deeper vessels, I will see beneath this black, I will be seeing the deeper episcleral or the episcleral vessels as such. So using the green filter is a very useful tip or a technique to identify the different levels of blood vessels when everything gets congested. And also you can use this cotton bud. This cotton bud can be used to move the conjunctival vessels over that underlying sclera. The conjunctival vessels will move, the episcleral vessels will move over the underlying structures, whereas in scleritis, the deeper episcleral plexus or the scleral plexus vessels will not move because they're adherent to the sclera. So that's what I've told. Now, just to revise everything quickly, in a red-free light, okay, in a red-free light, you can see episcleritis as a salmon pink appearance, which is radiating like this, whereas scleritis will be crossed, okay, and they have this violaceous hue. Okay. The most important tip I should mention now is that whenever you examine a patient with scleritis, always examine under daylight. Okay, even before you put the patient on a slit lamp, examining under daylight is the key, because the daylight examination is going to give a very clear violaceous hue or the purplish hue. That's important. Okay, and as I just mentioned, with the cotton tip applicator, you can displace the vessels in episcleritis, whereas you cannot displace the vessels in scleritis. And we already just discussed the blanching part of it. So let's go for the pictures now. Now this is episcleritis. This is episcleritis. You can see this kind of a bright red appearance, okay, and you have a very unique pattern of distribution of these vessels. And this is going to appear like this. The base is here, okay, the base is here, whereas the apex is here. This is episcleritis. Whereas in an inflamed pterygium, you will appreciate it like this. It will be like this. This is how a pterygium grows. The apex is towards the cornea, the base is here, whereas just the ulta or just the opposite for episcleritis. Now note how severe the scleritis eye looks. You see, you have not just the superficial but rather deep vessel involvement is also noted here. And you also have this kind of a violaceous hue. You can appreciate this violaceous hue better under daylight, and that's what separates scleritis from episcleritis. And very important tip is on slit beam, especially when it comes to nodular episcleritis versus nodular scleritis, there are two beams in a slit lamp. One is going to be a superficial beam, the other is a deep beam. The superficial beam will be raised, but the deep beam will stay low, or it will stay on sclera in case of a nodular episcleritis. This is a nodular episcleritis. Whereas in a scleritis, what happens is not just the superficial but also the deep beam. So both the beams are going to get elevated because of the underlying scleral edema, right? So that is a very important differentiation between episcleritis and scleritis as well. So let's talk the details. Now we have found the differences between, we have learned the differences between these two very much mimicking conditions. Let us discuss some few details on it. Episcleritis most commonly occurs in females, a young female or a middle-aged female presenting as a bilateral idiopathic benign redness. The most important thing is the recurrence. Recurrence is the key history to ask in episcleritis. because recurrent episodes of redness will occur in these patients and they are rarely systemic involvement. Rarely systemic. I won't say it's never systemic, but you can expect systemic involvement, but it's quite rare. And since it's rarely systemic involvement, it's mostly a localized pathology, there is no need for any systemic treatment. Contrary to scleritis, you require a systemic treatment. But in episcleritis, there is no need for any systemic treatment. Just topical NSAIDs or topical low-dose steroids will do. Now that's with episcleritis, and you have two types of episcleritis. One is a diffuse episcleritis. When I mean diffuse, I mean that I cannot see the border of inflammation. Diffuse is contrary to nodular. Okay, both are opposites. Diffuse means it's very ill-defined. Nodular means it's well-defined. Okay, so diffuse episcleritis will be kind of like this. It's ill-defined redness here. Whereas a nodular episcleritis, you have a painful nodule. Yes, you can have a tender nodule. Okay, but I just mentioned the slit beam will kind of differentiate between the nodular episcleritis as well as a nodular scleritis. So this is this tender nodule or very congested looking nodule which is seen in nodular episcleritis. Now let us talk about scleritis. Yes, we come to the main topic now. So scleritis can be differentiated into an anterior scleritis and a posterior scleritis. Posterior means it is posterior to ora serrata. That is what posterior scleritis means. We'll discuss about it in a moment of time. But anterior can be infective and non-infective. Why it's important to differentiate infective and non-infective? It's because infective scleritis does not require steroids. In fact, using steroids are contraindicated in infective scleritis. Whereas the main treatment option in non-infective is using steroids and immunosuppressive. And also in infective, you can biopsy, but non-infective, you cannot biopsy. Because you have to biopsy infective scleritis to find what is the pathology or what is the microbial organism causing the scleritis. Right. So that is why you should have to differentiate infective and non-infective. Coming back to non-infective, we can again split into necrotizing and non-necrotizing. Now why it's important again? Necrotizing indicates severity. Necrotizing indicates there is an underlying active systemic autoimmune disease. Could be a vasculitis or could be connective tissue disorder. So it's a very, very important alarming thing to know that if it's necrotizing, there is a very important active disease. You have to go there and search for things. The same applies to non-necrotizing, but necrotizing is relatively more severe when compared to non-necrotizing. Right. Necrotizing can again be classified into with inflammation, without inflammation. So if it's going to be with inflammation, yes, it's a very severe. In fact, the most severe type of scleritis is the anterior non-infective necrotizing scleritis with inflammation. If it does not have inflammation, is what we commonly call as the scleromalacia perforans. We will discuss that in a moment of time. So scleromalacia perforans is the term you give for anterior non-infectious necrotizing scleritis without inflammation. Now, non-necrotizing can be classified into nodular and diffuse. They are not necrotizing, but they appear red. They are the typical acute red eye picture. And the most common variety is the diffuse. The most common type of scleritis is diffuse non-necrotizing variety, whereas the most severe is this necrotizing with inflammation. Hope you now know the differences. I think I've made the classification as easy and as simple as possible. Now, pictures for each. Now, we'll talk about the diffuse, which I said the most common variant or most common type. Now, just appreciate this. Look how red the eye is. See, when I mean diffuse, I don't mean that it's entirely occupying sclera. When I mean diffuse, I mean it is flat. It is ill-defined. So, it can be sectoral, it can be diffuse, but in this picture, it's more of a diffuse. You can see that it is more of here, right? And you can also see that deep vessels are being involved, not just a superficial one. These superficial ones, but the deep ones are also getting involved, which means that deeper scleral vessels are getting involved. So see, this looks like a circumcorneal congestion which we see in uveitis, but it is not. This is a scleritis patient who is suffering with pain. Okay, The AC may or may not be normal. Most commonly, scleritis will have a quiet AC, but at times, yes, scleritis can be associated with anterior uveitis also. So it complicates the picture, but just know that this is how an anterior scleritis can present. The nodular is more easy to pick up because you have a nodule there. So you either think of a nodular episcleritis or nodular scleritis, and you know how to differentiate both. The same three P's I said: pain, purple, persisting, and not just that, you can use the slit lamp beam to differentiate nodular episcleritis versus scleritis, and you know how. This is another picture showing the nodular episcleritis variety, and nodular scleritis, and I also mentioned the slit lamp beam. See the elevation of both the beams because of the underlying scleral edema. Now, the necrotizing anterior scleritis with inflammation. This is a very important point because you can see inflammation here and it is necrotizing. So far we have seen the non-necrotizing, but this is the necrotizing one. Now just understand this. You can see this avascular necrotic plaque. It is necrotic. It is avascular, which means it is ischemic. So it's an ischemic necrotic avascular patch or a plaque which is on the sclera. This means the scleral inflammation is so severe enough to cause necrosis of the sclera. So eventually it will go for thinning, it will go for rupture. That is the importance of this. So there's an underlying disease which is very active, which is very much threatening the life of the patient. And this is again another picture showing the necrotizing anterior scleritis with inflammation. You can see the white avascular areas here. Okay, this is the most important part. This is the thinned out area with the uveal show. So you can appreciate this. You can appreciate this white avascular area is that necrosed area, and because of the thinning of the necrosed area, there is a scleral thinning, the underlying uvea is kind of showing. So this is what we call as the uveal show because of the scleral thinning, right? Now we can classify the necrotizing anterior scleritis with inflammation into three types. 1, 2, 3. The first is called as the vaso-occlusive. Because of the occlusion of the vessels, the underlying systemic disease is going to cause occlusion, or they're going to cause this immune complex deposition causing the ischemia of the sclera. The most common cause being the rheumatoid arthritis, being the most common cause of vaso-occlusive type of necrotizing anterior scleritis with inflammation. The second one is going to be granulomatous, which is very commonly seen in case of a very destructive condition called as Wegener's granulomatosis. The third is a very interesting and very unique one called as SINS. So what is the SINS? SINS means it's a surgically induced necrotizing scleritis. It's surgically induced. So what surgeries can induce? Any surgery can cause the SINS. Okay. When I mean any, I mean the most common is going to be two things. One is going to be a trabeculectomy can cause, because that's what any superficial surgeries, a trab, or it can be a pterygium excision which can cause the SINS. SINS is going to be a non-infective one, but if there is going to be one infective organism which can be associated with SINS, the most common organism causing SINS or associated with SINS is going to be Pseudomonas aeruginosa. Pseudomonas aeruginosa is the most commonly implicated organism in SINS. Okay, and the most important reason why you can have SINS, or a very important risk factor for the surgically induced necrotizing scleritis, is going to be use of mitomycin C. And you know where we use mitomycin C? We use in trab, we use in pterygium, and that's why in trab and pterygium the SINS is very, very common. So mitomycin C is the most important drug or most important chemical agent which can cause necrotizing scleritis. Now we have seen the three types of necrotizing scleritis with inflammation. Now let's talk about without inflammation. So as we just discussed in the classification, there is a name given for without inflammation, and that name is scleromalacia perforans, which means the sclera is going to be thinned out. It's a malacia. Malacia means thinning. So the scleromalacia perforans, contrary to the name perforans, it rarely perforates, but yes, it can happen when on exertion. You can see there is no inflammation as such. There is no congestion. Doesn't look very acute red eye like picture. Okay, there is no signs of inflammation there, but there is just this necrotic black patch is lying on the sclera, and you can see that eventually it'll go for a scleral thinning, so the sclera appears very bluish and thinned out with this underlying uveal show. It becomes so severe that you can even have perforation of the sclera. So three main important points are: in scleromalacia perforans, you don't have any signs of inflammation, either minimal or nil signs. There is no pain, no inflammation, so no pain like the other types of scleritis, unlike the other types of scleritis. And it is most commonly associated with rheumatoid arthritis. Very, very important. So RA is very much associated with your scleromalacia perforans. Okay. And not just that, just we discussed about the vaso-occlusive type of necrotizing anterior scleritis with inflammation. Okay. And you will know why RA is so important in just a minute of time. So this is a picture showing that in this without inflammation scleromalacia perforans, you can see the entire sclera has melted out, causing the uveal shore uveal prolapse here. Now let's talk about the complications in a quick moment. So you can classify into a scleral, corneal and others. The scleral complications are very obviously the thinning, the staphylomas again, the thinning with the uveal show, eventually going in for a rupture or a perforation. But the most important visually threatening complication is going to be peripheral ulcerative keratitis. So corneal inflammation or sclerokeratitis picture, or this PUK, is going to be the most important visually threatening complication. But the most common cause of eventual loss of vision is glaucoma. Why there is a glaucoma? There is a scleral edema, there is scleritis, so there is going to be a rise in episcleral venous pressure. This rise in episcleral venous pressure can go in for a rise in IOP, eventually leading on to glaucoma, as you always know. So as I just mentioned some time back, uveitis can also be associated with scleritis. So it is very important to examine the anterior chamber for any intraocular inflammation as such. Cataract is obviously going to have cataract in any complicated cases. But the end result of scleritis is going to be an eventual phthisis or a shrunkening of the globe called phthisis bulbi. So we have this important grading. So this grading is not important, remember, but the name is important. It is the McCluskey and Wakefield classification or grading of scleritis. You may pause the video to read by yourself the different grading and what do they mean. So that is the grading of scleritis. Yes, we come to the most obscure. See, anterior scleritis is obscure, but posterior scleritis is even more obscure and very mysterious. In fact, it is one of the most underdiagnosed entities because it's very easy to miss posterior scleritis. How a patient can present with posterior scleritis? A patient will present with painful defective vision, okay, and the pain will be on extraocular movements. Now, why there is a pain on extraocular movements? Because there is scleral edema. Okay, there is an edema of sclera in posterior scleritis also, and when you have the insertion of the extraocular muscles get inserted. Let's say these are the extraocular muscles getting inserted. So at the insertion point, you have pain. So there is edema there. So when the patient moves the eyes, you can have pain on extraocular movements. Right, that is one thing. The second is you have a defective vision because of the involvement of optic nerve or macula. Right. So it's a painful defective vision extraocular movements. The patient will have defective vision because of optic nerve involvement or macular involvement accordingly. Sometimes because of the scleral edema, the patient may also present with proptosis. Right. These are clinical features. Let's see the signs. You can see there's a variety of signs. It's like a kind of a masquerade. Now here you can see a circumscribed mass at the posterior pole in posterior scleritis. This looks like a choroidal melanoma or a choroidal mass, and you can see an exudative RD here with associated retinochoroidal folds. A very important finding in posterior scleritis is retinochoroidal folds, as already seen here. You have this RC or chorioretinal folds there. Sometimes the patient can also have this disc edema like picture. Now this exudation or this subretinal fluid exudates can also be seen in the macula. That's why there are two important differential diagnoses for posterior scleritis. The first and the foremost is going to be CSR, a central serous retinopathy. The second differential is a VKH syndrome or Vogt Koyanagi Harada disease or a syndrome. VKH can present with bilateral disc edemas, okay, with multiple pockets of subretinal fluid or subretinal exudative RDs can be presented. Similarly, CSR will have SRF, subretinal fluid at macula. The reason why I want to say that CSR is important to differentiate because the treatment for posterior scleritis is steroids. But you should never give steroids for CSR because steroids itself can cause CSR. But for posterior scleritis, you should give steroids. So knowing the difference between both is of prime importance from a treatment perspective. Both have opposite ways to treat, right? Yes, the most important thing or the most important diagnostic modality to diagnose posterior scleritis is going to be a B scan. When you do a B scan, you can find a very important sign called as the T sign. Why this T sign occurs? Because of the scleral edema, there is going to be the subtenon fluid accumulation. So as you can see here, you can see a subtenon fluid accumulation here at this area. And you can see the optic nerve shadow here as well. So this subtenon fluid collection with the optic nerve shadow is what we call as the T sign. It's a very important sign. And also there is going to be this scleral thickening or RCS, retinochoroidal scleral complex thickening can also be noted in case of a posterior scleritis. Infectious scleritis, as I just mentioned, is very important to differentiate from non-infectious because of the mentioned causes. You don't give steroids in infectious scleritis, but how to diagnose them? The more important features are going to be exudates or infiltrates, ulcers and abscesses. So when you see a scleral abscess or a scleral purulent exudate, then think of infectious. The most common cause of infectious scleritis is herpes zoster ophthalmicus. The herpes zoster infection is the most common cause of infective scleritis. You can see a focal necrosis in a herpes zoster infection. You can see a nodular lesion in a TB lesion. This is another nodular scleritis in Lyme's disease, very much mimicking like a non-infective one. And this is a fungal infection, multiple avascular areas of sclera. So as I just mentioned, very important, you have to investigate for the cause. Therefore, the only indication where biopsy may be required is infectious scleritis. The treatment is antimicrobial and do not use steroids and immunosuppressives in infectious scleritis. Out of these three drugs, bisphosphonates, this drug called erlotinib and procainamide, these three drugs are commonly implicated to cause scleritis. You know, bisphosphonates are used to treat in osteoporosis. But as I just mentioned some time back, the most important drug or most important chemical which can cause scleritis is going to be your mitomycin C. That is the first drug. Then comes the rest. Now we move on to the systemic associations of scleritis. So we can classify systemic associations into two types. One is non-infective, infective. Yes, of course, infective conditions like syphilis, TB and herpes can also cause scleritis. But our concern is a non-infective one. We can again classify them into connective tissue diseases and systemic vasculitis. There are two different categories here. Amongst the connective tissue diseases, the most important is rheumatoid arthritis. In fact, the most common systemic association or systemic disease in scleritis is rheumatoid arthritis. Very, very common. And less commonly you can see SLE or systemic lupus erythematosus. The other is the relapsing polychondritis or RPC. Amongst the systemic vasculitis, the most important disease is going to be Wegener's granulomatosis. Recently, they have renamed as granulomatosis with polyangiitis. Now, Wegener's is going to be the most common vasculitis condition to cause scleritis. The most common systemic association is RA, but whereas the most common vasculitis is Wegener's. Apart from Wegener's, you have microscopic polyangiitis, you have polyarthritis nodosa, and you have Church-Strauss syndrome. These are less important, but these two are the key. Okay, some quick points to understand RA. You have symmetrical arthritis, early morning stiffness, characteristic skin nodules, and characteristic joint deformities. Yes, rheumatoid factor helps a lot. And the typical deformities expected in RA is going to be the two things. One is swan neck, other is the Boutonnière's deformity. You will have the flexion of the proximal interphalangeal joints causing the swan neck. Okay, so this is what it is. So PIP is like this, DIP is like this. Okay, whereas Boutonnière is just the opposite of it. So the two important deformities are swan neck deformity and the Boutonnière's deformity. With the relapsing polychondritis, the patient will often present with an acute painful swelling of the pinna. So there's going to be a polychondritis. There's going to be inflammation of the cartilage. The cartilage, one cartilage is going to be the pinna or the earlobe. The other cartilage is the tracheobronchial cartilage, which is life-threatening because it can cause asphyxia. Like in this patient with RPC, the patient underwent tracheostomy because of the tracheal collapse. And also there's a nasal cartilage destruction causing this classic saddle nose deformity. SLE is very commonly seen, but of course scleritis is just associated only with 5% of patients. The typical mala rash is a very clinching diagnosis factor, and we always do the anti-DS, anti-double-stranded DNA as a very important test to conclude or to diagnose SLE. But ANA or anti-nuclear antibody test is going to be a very common screening test used to diagnose SLE. Vaginous granulomatosis or granulomatosis with polyangiitis is a highly destructive lesion because they can involve paranasal sinuses, your lungs, as well as the kidneys as well. So they can cause epistaxis, sinusitis, hemoptysis, and hematuria. The most important point is it can cause lung cavitations. So one of the very few autoimmune diseases which can cause lung cavitations is going to be vaginous. And vaginous you can diagnose with C and K, which is cytoplasmic antineutrophil cytoplasmic antibody. That's C and K. Whereas for PAN it is P and K. I'll just come to about it in a minute. This is the picture showing this destructing nasal cartilage with this necrotizing scleritis, showing this necrotizing patch here. As just mentioned, PAN equals P and K. Vaginar equals C and K. So what is P and K? It's a perinuclear ANCA is the test we do for PAN. Now PAN is going to be an aneurysmal vasculitis. So you can expect aneurysms in the mesenteric vasculature or in the renal vasculature also. Okay, that's why it can cause intestinal angina and some GI symptoms can be caused. This is PAN or polyarthritis nodosa. Now let's come to investigations. As just mentioned, you have to use P ANCA for PAN and you have to use this C ANCA for vaginous. That's the importance of the P ANCA and C ANCA. These are these ANCAs. We use ACE or angiotensin converting enzyme levels for sarcoid. Yes, sarcoid also can be implicated in scleritis as well. Rheumatoid factor for rheumatoid arthritis. Antinuclear antibody for SLE. Apart from that, we can take chest x-rays to rule out TB, to rule out sarcoid, to rule out vaginous as well. Treatment options are many, but the most important being the medical treatment. Surgical is the last resort when you have typical necrosis or perforation of sclera. We can go for a patch graft of sclera. So the patch grafting is going to be the surgical modality. We're going to graft a preserved sclera. A preserved donor sclera can be used for patch grafting. But most commonly used treatment option is going to be the medical treatment. You have topical, you have systemic. For topical, you have NSAIDs and steroids. Note, topical is used only for episcleritis. Okay. In other words, I can use topical in systemic but only as an adjunct. Okay. You cannot give topical therapy for systemic. There is no role for local therapy or local treatment in scleritis. You have to start the patient on a systemic treatment. It can be an oral steroids, it can be an oral immunosuppressive, or it can be an oral NSAIDs. It doesn't matter, but there is no role for only local treatment in systemic in scleritis. For episcleritis, we can go for NSAIDs and steroids. Amongst the systemic options, we have NSAIDs, we have steroids, we have immunosuppressive. The most commonly used oral NSAID is going to be indomethacin sustained release capsules, Indocap SR, what they call. Now, this indomethacin tablet can be started in a patient who we suspect scleritis initially. If not responding, we can switch over to an oral steroid later. The oral steroid being the prednisolone tablet, slow tapering doses, 1 milligram per kg per day. But in case of maybe a more severe type of scleritis, which is vision threatening or the scleral threatening inflammation, we can go for the intravenous methylprednisolone, 500 milligram to 1 gram IV infusion. Immunosuppressives are given in very selected conditions. If steroids are not responding, if you have adverse effects because of steroids, you can go for immunosuppressive. And not just because of that, sometimes when you have certain diseases which require to start immunosuppressive at the very first. We'll discuss about that in a moment. So just understand this. The first line is going to be an oral NSAID, topical steroid as only as an adjunct. I mean, just to support it, not alone, never alone. So start the patient oral NSAID first. If not responding, to systemic or oral steroids or IV steroids accordingly. Still not responding, go for immunosuppressant. But understand, in necrotizing scleritis, the first line is immunosuppressant. That is the most important thing, because you want to hit that inflammation hard and fast. So immunosuppressive agents can be basically classified into non-biologics and biologics. The biologics, the most commonly used is rituximab in scleritis. But the more commonly we use a non-biologic. Amongst them, we can classify into antimetabolites, T-cell inhibitors, and alkylating agents. It's very easy to remember them. You call auntie. So you call someone as auntie, I will refer to them as ma'am, right? There's the A there, but forget that, it's ma'am. So antimetabolites are azathioprine, methotrexate, mycophenolate mofetil, MAM. So methotrexate, mycophenolate mofetil, and azathioprine are antimetabolites. T-cell inhibitors, there are names in that, the first letters. You have a T, you have a C. Tacrolimus and cyclosporin are the T-cell inhibitors, whereas the alkylating agents are the two C's, cyclophosphamide and chlorambucil. Don't mix this. Tacrolimus, cyclosporin are T-cell inhibitors. They are a combo, very commonly used in corneal diseases as well. But whereas alkylating diseases are very, very important, very severe, treated, given only for very severe conditions, cyclophosphamide is very important. Why? Because cyclophosphamide is going to be the drug of choice, in vaginous granulomatosis. Because vaginal granulomatosis is so severe, so destructive, I want to start the patient immediately on cyclophosphamide, which is the most potent of all immunosuppressive agents. So the indications for immunosuppressive treatment, to recapitulate, it's going to be the anterior necrotizing scleritis, the posterior scleritis, the scleritis associated with any autoimmune disease or a collagen vascular disease. So any necrosis, any underlying systemic pathology, it is wise to start the patient on immunosuppressive. Now that ends with this discussion on scleritis. I hope I've made it as comprehensive and as clear as possible. So if you have kind of forgotten whatever I've told you, I think you can remember by the two S's. Systemic. Search for systemic autoimmune diseases in scleritis. Systemic. There is no role for local therapy. You should give a systemic treatment only. 3 P's. Painful, purple hue of the blood vessels, persisting with topical vasoconstrictors. So that is with the scleritis. Now, I want to put everything into perspective as acute red eye. Just hang on with me. I know you might get lost now, but this is the most important part. Why? Because explaining scleritis is not a big thing. Anybody can talk about scleritis, the types, the varieties, and so on and so forth. But when a patient comes to me with an acute red eye, how am I going to diagnose the patient? Am I going to miss scleritis or not? That is the most important question to answer. So let us take this approach. I will always consider an acute red eye under two headings. One is presenting the normal vision with a reduced vision. Anyone who presents the normal vision, I will look for any discharge, follicles, papillae, a diffuse congestion of conjunctival vessels. You can see it's more of a fornicial congestion. Congestion localized on the fornix, follicles, papillae. The fornicial congestion will spare the limbus. So it starts from fornix to limbus. It will spare the limbus. That is acute conjunctivitis. Can be infective, can be allergic, it doesn't matter. But that is acute conjunctivitis. Whereas if it's going to be a painful, recurrent episcleral or a deep episcleral congestion, then that is scleritis. Because scleritis is painful. It can have defective vision only if cornea is involved or you have an associated cataract or other complication. But scleritis per se will have normal vision. It warrants systemic evaluation and no role for local therapy, only systemic therapy, just mentioned now. But its close resembling cousin is going to be the episcleritis, where it is painless, rarely painful, mild irritation, episcleral congestion, that is episcleritis, which is self-resolving, right? So as far as a normal vision is concerned, it's going to be acute conjunctivitis, scleritis, episcleritis. Just keep it in mind. But what about the reduced vision? See, among the normal vision, scleritis is the most threatening one, most dangerous villain. But amongst the reduced vision, I think all of them are threatening, vision threatening, all of them are very important. The most important being the acute angle closure glaucoma. A patient coming to me with pain, redness, photophobia. The patient is so much in pain, he's vomiting, he's having nausea, he's having malaise. There is rise in IOP, there is a corneal edema, there's going to be narrow angles, a circumcorneal congestion as you can see in this picture, which means a diagnosis in acute angle closure edema. This corneal edema is the most important picture, most important point to consider, along with the narrow angles in acute angle closure glaucoma. Sometimes you can have a corneal lesion which can present with a pain and photophobia. So always look for an acute keratitis. And yes, let us not forget the close important thing with this topic is the uveitis. So a patient can present with a pain, more photophobia. You may or may not have an IOP raise, but you will have an AC reaction. You may have a keratic precipitation endothelium presenting with a typical ciliary injection or what we call circumciliary congestion in acute anterior uveitis. In this picture, you can see the CCC along with posterior sinus A. So, normal vision, it's going to be an acute infective conjunctivitis or an acute allergic conjunctivitis. Second is going to be episcleritis. Third is the more important scleritis. With reduced vision, you have the three important acute anterior uveitis, acute angle closure glaucoma, and acute keratitis. See, I think I've made it as clear as possible just to bring back this analogy. We have multiple villains, we discussed about the villains now, and we brought scleritis, and we discussed about scleritis and how to differentiate scleritis from its closest cousin, that is the episcleritis. And we talked about scleritis and the mafia gang or the people who employ scleritis, that is systemic autoimmune diseases. That is it with scleritis. So thank you so much for listening. Your support and love means a lot. Thank you.